Welcome to the Dental Capsule. In this series, we'll cover different dental topics and real clinical situations in short, easy-to-follow capsules, designed to help us improve how we manage our daily cases.
In this capsule, we'll cover 5 important endodontic tips that can significantly improve your root canal treatment results. First, never start root canal treatment without a solid diagnosis. A tooth that truly needs RCT usually falls into one of 3 categories. Irreversible pulpitus, which often presents as sharp, poorly localized pain that becomes much worse with cold and is confirmed with cold pulp testing. Pulp necrosis, where the tooth does not respond to thermal tests, but is tender to percussion because of periapical irritation. Or the tooth may be completely asymptomatic, but the radiograph shows deep caries approaching or involving the pulp chamber. Always make sure you are treating the correct tooth. Referred pain, periodontal problems, or even maxillary sinusitis can easily mislead you into starting treatment on the wrong tooth. Second, design your access for visibility, not just entry. Conservative access should never mean blind access. Your access cavity must give you clear visibility of the pulp chamber and canal orifices so you can clean, shape, and negotiate the canals properly. This becomes critical when searching for extra canals, like the MB2 in maxillary molars, or a second distal canal in mandibular molars. Narrow or restrictive access also places unnecessary stress on rotary files, increasing the risk of instrument separation. It can even prevent files from contacting and cleaning certain canal walls because of tension at the access cavity. Third, always combine the apex locator with radiographs. Neither method alone is enough. Radiographs show you the radiographic apex, but not the anatomic apex, which is often located slightly coronally. Using the apex locator alone is also risky. It gives no information about root shape, canal curvature, or canal configuration. And in some cases, poorly calibrated or incorrectly used apex locators can actually hide working length errors. When you combine both tools, you gain accuracy, safety, and confidence. Fourth, use rotary files passively. Never force them. Rotary instruments are designed to cut efficiently with light pressure, not with pushing or aggressive force. Forcing a rotary file increases torsional stress and cyclic fatigue, which greatly raises the risk of file separation. Excessive pressure can also pull the file beyond the working length, leading to apical transportation or over-instrumentation. Let the file progress smoothly and withdraw it frequently to clean the flutes and release stress. If the file is not advancing, stop and reassess the glide path, irrigation, or coronal pre-flaring. The solution is never more force. Fifth, never underestimate the importance of a proper coronal seal. Even a perfectly clean and obturated canal can fail if coronal leakage is present. Saliva and bacteria can quickly penetrate through defective restorations and reinfect the root canal system. In fact, many endodontic failures are caused by coronal leakage rather than apical pathology. A well-sealed temporary or permanent restoration protects your endodontic work and ensures long-term success. And even if the final restoration will be delayed, placing a thin layer of flowable composite over the gutta percha can help prevent leakage if the temporary fails or if the patient doesn't return on time. This was part 1 of our endodontic series. In the next parts, we'll share more practical tips and clinical pearls to make root canal treatment safer, more predictable, and more efficient.
Thanks for watching. If you found this helpful, don't forget to like and subscribe. Share your thoughts or questions in the comments. We'd love to discuss them with you. See you in the next capsule.